In this session, we'll be discussing mostly about valve and valve TAVR. The co-chairs of this session will be Dr. Jang Ki-yuk from Seoul St. Mary's Hospital, Dr. Yu Cheol-woong from Korea University Yanam Hospital, and Dr. Kim Joo-han from Jeonnam University National Hospital. Dr. Jang, please.
Dr. In.
Hi, Dr. Zhang.
Hi, nice to meet you again.
Nice to meet you again.
Yeah,
Welcome.
First of all, I'd like thank you to inviting our team to your Taipei summit. I didn't say any. Thank you.
We are so happy that you can come and enjoy the stay in Taipei. Yeah.
Okay, we expect your lecture. And
Thank you.
Dr. Danny DeBeer. Are you there, Danny? Oh, nice to meet you.
Hi, do you see me well?
Yeah, I'd like you. Thank you for joining our symposium. This Jeju Valve is a small symposium where interventional cardiologists in Korea gather together to share their experience in structural heart disease intervention. So we have been anticipating your lecture on Basilica. Actually, we all know you are the inventor of Basilica. So today we are happy to hear your lecture from you. And I'd like to introduce Dr. Danny DeBeer, first speaker. He was born and educated in Israel and moved to United States and completed interventional cardiology fellowship at Washington Hospital Center, and then worked there as a faculty in cardiology department. So today his topic is on Basilica. So please, Dr. DeBeer.
Recording in progress.
Okay, thank you. Thank you so much for the opportunity to present to you. And I remember my visits to Korea to teach the teams about how to perform the procedure. So very good times with the different teams. So do you see my slides well?
Yeah, we can see here clearly.
Okay, perfect. So when we talk about Basilica and Shortcut, and there are other tools also in progress, we talk about methods to prevent a devastating complication of TAVI procedures. And this is a coronary obstruction. Coronary obstruction is a very bad complication that we need to identify patients at risk for, and we need to prevent it in all costs. It's associated obviously with the high mortality rate. We know how to identify patients at risk for coronary obstruction. There are many different classifications, but basically we always need to identify what would be the residual flow to the coronaries, how the anatomy will look like after we deflect the leaflet. And that leaflet could be the native leaflet, it could be a degenerated surgical valve, it could be a degenerated TAVI valve when we do TAVI in TAVI, and we'll talk about it. The most common method worldwide to prevent coronary obstruction is called chimney or snorkel technique. It is a method that utilizes a stent to push the leaflet a bit out of the coronary ostium, or to enable the STJ flow towards the sinus to prevent the sinus sequestration. And there are many old descriptions on how to do it effectively, the stent protection method. This is not a complex method to do, but that method is not optimal because it is not designed to prevent coronary obstruction by implanting stents. Stents are designed to treat atherosclerosis. And there are many potential challenges related to the durability of that technique. And we all can understand what can happen also when you try to bring these stents back and you are jailed and you're not able to bring them. So it is clear that we need to orient ourselves, this is what we understood, towards the origin of the problem. And the origin of the problem is the deflected leaflet. We deflect leaflets in TAVI procedures, the original native leaflet in native TAVI or in valve, it's a bioprosthetic leaflet. So we need to modify that leaflet in a way that it will prevent coronary obstruction. And we understood over time that a single leaflet tear can prevent coronary obstruction. If we are able to make a slice in a leaflet, that leaflet, when deflected, will not cause coronary obstruction in the same magnitude that it may have caused without deflecting it. And you can see here a couple of examples of what happens to a leaflet that has a tear when you deflect it. It displays and enables flow through the split between the parts of the leaflet. This is a picture from the first in-human basilica procedure that I was fortunate to perform in July 17. It was now 6 years ago, and in Seattle. We didn't know about the potential risks of splitting aortic valve leaflets. We were guided by a team in the NIH that already has done some lampoon procedures with splitting of mitral leaflets. And as you can see, the table is filled with a lot of equipment. Some of these things are not necessary maybe anymore. And we still did the protection to the left system with the guide and the stent, like the chimney technique, because we didn't know whether we will be successful or not. And here is a small cartoon of how basilica is performed. Basically, we need to stand behind the leaflet that may cause coronary obstruction. In the LVOT, we open a snare. We electrify a wire and deliver it through the leaflet that we intend to tear. And later on, we electrify that wire again and pull both catheters back. And after that leaflet is cut, we are able to perform TAVI, and hopefully we will not have coronary obstruction. So the method of how to do basilica is described in many different publications, and you can read it. I can say clearly that the most important step in how to do basilica procedure is the leaflet traversal, or step number 4 in the slide that you see here. You need to stand behind the leaflet in a correct fashion in order to traverse it with the leaflet. A minor inaccuracy in that positioning will lead to inability to cross it. So with the introduction of leaflet modification in TAVI procedures, basilica and other techniques, we need to introduce new nomenclature. Now it's clear to all of us that we need to talk about a single leaflet and not only on the perimeter of a valve area, coronary height. We need to talk about the leaflets and how to view these leaflets, in what are the projections that may orient the leaflets well in front view and side view. You can look at it in our different publications. But basically we know that this is the perpendicularity plane of the aortic valve that goes along from areocaudal to iliocranial. In different places along that perpendicularity plane, we are oriented to the different leaflets in an important fashion that it needs to be understood for the basilica technique. For instance, when we want to slice the left cusp, in iliocranial, there is a view in which we are isolating the left cusp, the left side view. In areocaudal, we are in frontal view of the left cusp, So obviously in the areocaudal view, we need to be in the center of the valve. In iliocranial, we need to be oriented with an attack angle towards the leaflet that we want to slice. This is basically, in short, the importance of different projections in the basilica technique. We also need to appreciate coronary eccentricity. We know now that some of the coronary ostia do not come in oriented towards the center of the leaflet. They are a bit towards the side of it. And when we have these conditions, we need to consider doing also an eccentric cut and not cutting the center of the leaflet. And obviously, the efficacy of doing basilica in these conditions when they are extreme is not as good. This is another argument to do good commissural alignment of TAVI devices in order to enable future leaflet modification that would be successful. So there were many basilica procedures performed for failed TAVI devices, and I must say there was originally a concern that it may not work, but it does work well also for failed TAVI devices. Here is an example of a patient with a failed a failed core valve device that needed a double basilica procedure. And I can say that double basilica procedures are complex. They require a lot of catheters sitting in the aortic root because you cannot slice one leaflet and then work on the other. You need to be prepared before you start slicing leaflets. So you have here 4 catheters sitting at the aortic root. In the right side of the screen, you see the left cusp laceration, and on the left side, the right cusp laceration, and later on, implantation of a sapien 3 inside that failed core valve with a good coronary flow, and that patient did very well later on. So basilica is not shy of adverse events, and since it was applied already to many hundreds procedures, we see many examples of things that can happen. But obviously, traversal adverse events are maybe the most common ones. Traversing the wire or not being able to traverse the wire in a abnormal fashion, like to be around the ring of the surgical valve to cause a fistula or to penetrate the aortic mitral curtain. Here you can see examples of mitral apparatus loop or injury to other places of the heart that can happen. Obviously, these are rare events. Most basilica procedures are not associated with adverse events. And the most common thing that we hear from different centers is inability to traverse the leaflet and the inability to perform the procedure rather than having an adverse event. The majority of basilica procedures, especially at the beginning, were performed with neuroprotection devices. Here's a piece of a mitral flow leaflet that we gathered from a Sentinel device in a case in Germany that I came to Proctor. It's quite interesting how these things can happen. Maybe we need to have neuroprotection in many of these cases. Here's an example of a devastating adverse event that happened also, aortic dissection. And again, these are extremely, extremely rare things that were encountered. Coronary obstruction can still happen after a leaflet modification, and it seems that we can reduce that risk dramatically, but it's not zero, and this is an Allegra device that still had coronary obstruction after basilica and needed a stent. And we can say that now, 6 years after the introduction of basilica, we still do not see many centers performing basilica independently. Also, many big centers that do a lot of TAVI procedures are still not independent in that. And it is clearly related to the off-label utilization of wire electrification and the challenge of traversing leaflets that I described before. So there are several devices that are dedicated for splitting aortic valve leaflets. The most known is the Picardia shortcut device, and I'll show you a short cartoon describing it. This is a device that goes transfemorally through regular 16 French sheath. You can go through a smaller one as well. You unsheath the device. And here it comes. It has a positioning arm and a splitting element. The beginning, and this is intended for left cusp laceration, the device is delivered behind the cusp that we want to split. So we bring it behind that cusp. There are several knobs that are utilized for that. You are able to rotate the device also. And when you are in the correct position, you deliver a splitting element from the LVOT that punctures the leaflet that you want to split. And later on, by a gentle push on the wire, the left ventricular wire, and gentle pull on the catheter, you're able to split that leaflet. This is after doing numerous of shortcut procedures. I can say that this is a very, very quick and easy procedure to do that may solve the challenges of the basilica technique. So these are different valves that we tested with a shortcut. And this is an animal evaluation, porcine evaluation of splitting of right and left cusps, native cusps. So we described in recently, less than a year ago, the first 8 cases performed with shortcut. Nowadays, there are more than 50 procedures that were performed. And I can say that we are very pleased with the results of the shortcut device, also in very old and sick patients. You can see that some of these patients, patient number 2 was 96, and some of these cases were quite extreme. None of these patients died or had stroke or had coronary obstruction. You can see the clinical characteristics of these patients. We also treated the failed TAVI devices that I will describe. These are the vivid classification characteristics of these cases. The majority of them were cases at risk for left coronary obstruction. Some of them were combined left and right. 5 cases were left, 3 are right. The average procedure time was 19 minutes of the shortcut procedure. And there is a study ongoing now in Europe and in the US evaluating 60 patients having shortcut device. That study is about to finish, and I may say that we are quite pleased with the results until now. Until now, there are multiple degenerated valves that were treated with shortcut, including failed Evolute, Sapien 3, and Sapien XT. I'll show you several examples. You can see a case that is clearly at risk for right and left coronary obstruction. The anatomy is quite severe. Unsheathing of the device, landing the device behind the left cusp. We activate the splitting element and we split the leaflet. You can see it on the right side of the screen. After that, right cusp laceration, which is performed only by rotating a knob on the device and you are behind the right cusp. And then you lacerate the right. You resheath the device, you withdraw it, and you quickly deliver the TAVI device. It is surprising, but almost all of these patients having leaflet modification do not have hemodynamic instability. It seems that leaflet tears by themselves are tolerated well when you do TAVI after a couple of minutes. Here's an example of shortcut that was performed for failed SEPIN3. And here is an example of a shortcut that was performed for a failed SAPIN XT that was associated with the risk for coronary obstruction. And here is maybe a more complex case, a failed Evolut. We know that some of these supraannular devices, especially when implanted high, could be associated with high risk of coronary obstruction. You can see that these patients could be complex to treat. You can see on the left side how the left cusp leaflet, if we push it, it may close the flow to the left main, and the same thing on the right side of the screen with the right coronary. This is a shortcut procedure that was very successful, splitting the right cusp, and afterwards rotating the knob and splitting the left cusp. And this is the end result, good flow towards the coronaries, no issues. The patient did very well later on. Just before I finish, I'll describe two novel things that could be associated with these devices as well. This is an example of a shortcut that was applied to modify the anterior mitral leaflet transapically before a Tendyne procedure, TMVR procedure, that was performed as well. This is intended to prevent LVOT obstruction. That was a very successful procedure. Another utilization of leaflet modification can be to modify bicuspid valves by slicing para-raphe in order to improve the expansion of the TAVI device later on. Or we call it aortic root tricuspidization. Here is an example from one of these procedures with a basilica technique. No shortcut was applied yet to these anatomies. You can see the laceration. And later on, good expansion of the valve that was implanted. You can see also laceration, the basilica technique of a type 0 bicuspid valve. So I'd like to summarize that coronary obstruction is a life-threatening complication of TAVI procedures. Basilica splits aortic cusps that may otherwise cause coronary obstruction. It has been applied to many hundreds of patients with rare major adverse events that I described. With the expansion of TAVI into younger populations and as multiple valve interventions may be required for patients with AS, there is a real need for a dedicated leaflet splitting device, and shortcut is one of them. It allows for controlled and simple splitting of single or double leaflets with short procedural times, only a couple of minutes. Effective leaflet splitting was successfully performed without coronary obstruction, stroke, or vascular complication, and shortcut pivotal study is currently enrolling in Europe and the US. Leaflet modification may also be advantageous in selected cases of bicuspid or heavily calcified aortic valves unrelated to the risk of coronary obstruction. So I'd like to thank you again for inviting me, and happy to take any questions you may have.
Thank you for your excellent lecture, Dr. Danny. The discussion will be done after all the lectures. Please wait.
Okay. Next topic is valve fracture. Is it mandatory in valve TAVI? Performed by Kwan-Yong Lee. Please save time.
Okay, thank you, Dr. Yu. It's an honor for me to have a speech here today. Today I would like to talk about the topic of valve fracture. Is it mandatory in valve TAVI? Valve TAVI has proven to be a safe and effective treatment for patients with failed surgical valves, and the use of valve procedure is increasing. Elevated residual transvalvular gradients may occur following valve TAVI, particularly in the presence of a small bioprosthesis with a label size of 21 millimeter and under. In previous data, the smaller the initial surgical valve, the higher the mortality after valve TAVI was observed. Novel techniques such as bioprosthetic valve fracture has been explored to address these issues. Valve fracture increases the internal dimensions of the surgical valve, improving expansion of the TAVI valve. After successful valve fracture, residual vascular gradients can reduce and effective orifice area can increase. Therefore, for optimal TAVI, in cases anticipating PPM, valve fracture should be done at the time of TAVI implantation. Well, luckily, most surgical valves can be fractured, and we usually need non-compliant balloons such as Atlas Gold. Initial step for high-pressure balloon inflation consists of a large syringe, inflator, and a high-pressure stopcock. Successful valve fracture is characterized by a sudden drop in the pressure on the inflator gauge and often accompanied an audible snap. For the proper balloon sizing, you should understand the valve anatomy, particularly when performing valve fracture after implanting a self-expandable valve. The valve has a narrowed area known as the constrained area. When using a high-pressure balloon larger than the diameter of the constrained area, trauma and valvular insufficiency can be occurred. Therefore, to minimize the chance of trauma, balloon size should not be larger than the constrained area, and to minimize the risk of tearing the leaflet, we keep the superior shoulder of the balloon below the constrained area. Then, when do you think is the right timing to do valve fracture? Before or after TAVI? When you do valve fracture before TAVI, high pressure inflation of TAVI processes is not necessary. However, the risk for embolization or severe AR can be raised. Maybe in that case, sentinel protection and rapid TAVI implantation would be required. On the other hand, when you do valve fracture after valve, the high pressure inflation ensures optimal expansion of TAVI processes. However, it also can lead acute injury to the valve and leaflet. A prior bench test report observed the impact of valve fracture timing on valve durability using accelerated wear testing and microscopic and histologic analysis. Sapien 3 and Accurate Neo were implanted to mitral flow surgical valve in 3 experimental setups. The hydrodynamic testing with 200 million cycles, which is equivalent to 5 years, were done. From the result, a valve fracture performed after valve was associated with a larger UA without increase in regurgitant fraction. After showed better than before here. From the histological analysis, valve fracture after valve is associated with more superficial damage. However, from the whole leaflet thickness analysis, ultrastructure was preserved. Then, how about the clinical outcomes after balloon fracture? Would clinical outcomes be different according to the timing of valve fracture? Let's see the recent publication. From the data of STS-ACC TVT registry, among a total of 2,900 valve cases, 21% underwent balloon valve fracture. From the safety outcomes, the attempted bioprocess valve fracture was associated with increased risk for in-hospital mortality. Valve fracture before valve-in-valve was also associated with increased mortality and no change in hemodynamic parameters, whereas valve fracture after valve-in-valve was associated with similar mortality and improved hemodynamic status. From this result, I would like to say that valve fracture after valve-in-valve is recommended. However, valve fracture before valve-in-valve need to be concerned. Then what are the complications of valve fracture? How to overcome them? Here are the summary of complications following valve fracture: stroke, pacemaker insertion, severe AR, mitral valve damage, coronary occlusion, VSD, annular rupture. And among them, I think the most terrific event would be coronary artery occlusion. In this coronary angiogram, you can see a very low left main in relation to mitral flow surgical valve with chimney root and no coronary sinuses into which the fractured valve can expand, which can increase the chance of coronary occlusion. Then how to overcome it? Now we can apply basilica and chimney stenting. There was a report compared two techniques at EuroPCR 2023 in Paris. Chimney stenting is a widely used technique to prevent TAVI-related coronary occlusion in patients at high clinical risk. You can see the stent deployment with generous protrusion like this figure. Here is our case who applied chimney stenting. The patient was 87 female, accompanied persistent AFib. From the CT analysis, a Bridget calcification observed, and left coronary height was only 4 millimeter. And 3 mentioned virtual planning warned coronary obstruction risk. In addition, we have been applied this virtual pre-procedure planning by our own 3D viewer as well. This virtual planning offers us intuitive insights about the risk of coronary obstruction. When we insert the valve, we see that there is a risk that the native leaflet here is pushed toward the left main ostium and blocking the blood flow into the opening. So we decided to use SAPIEN valve for easy chimney stenting. LCA protection with guide liner was done. We performed the pre-dilation first with a 60 millimeter balloon. You can see that during ballooning, native leaflet is blocking the blood flow. We performed TAVI and coronary stenting concomitantly using chimney stenting technique for this case. This is the final angiogram after chimney stenting and post-NC balloon. Let's get back to the EuroPCR reports. And even though the worst anatomical setting observed by CT in the basilica group, technical success rate was comparable, and minor bleeding and PVL were more occurred in chimney stent group. There was no difference of MACE incidence between two groups, but numerically higher CV mortality with chimney stenting was observed. The patient, here is our case of basilica. The patient was 82-year-old female who have AVR, TVR, and pacemaker insertion, AFib, CKD, and perimeter-derived diameter was only 17, and left coronary artery height was only 6.5 millimeter. The implanted surgical valve has a spec of 11 millimeter height. Therefore, if we put the Evolute R-TAVI valve inside the surgical mitral flow, the chance of left coronary occlusion is expected. We planned basilica before valve-in-valve TAVI, sentinel for embolism protection, and valve fracture for the optimization. So sentinel was placed, and basilica. And for basilica, we set up the snaring and traversal system. For setup of traversal system, through short AL guiding catheter, Davis neuroangio catheter, and fine cross and astato guide wire was sequentially placed. The electrifiable astato was connected to the bobby at its end and penetrating the degenerative surgical valves. The wire targeted the nadir of surgical valve leaflet and was snared and then externalized through the MP catheter system. The half portion of astato wire was previously decoded and made V-shaped in advance. The V-shaped portion was positioned at the target leaflet. Then, by pulling the electrified wire on both outer ends, the leaflet was split from bottom to tip. After successful basilica, Evoludar 23mm valve was smoothly implanted, and valve fracture was performed by using Atlas Gold 20mm up to burst pressure. You can see the widening. After valve fracture, we confirmed no complication and good coronary flow, and the retrieval of sentinel device showed embolic tissue material from the left side filter. Post-TAVI echo showed well-expanded round-shaped TAVI valve and Vmax reduced. So we successfully performed valve-in-valve TAVI in a patient with failed surgical valve. In this case, we used the sentinel device, performed basilica, TAVI, and valve fracture. So, ladies and gentlemen, here is my take-home message. In cases anticipating patient PPM, bioprosthetic valve fracture should be done at the time of TAVI implantation. And the timing of valve fracture is important. From the recent registry data, valve fracture attempted prior to valve-in-valve was associated with increased mortality, whereas the valve fracture after valve-in-valve was associated with similar mortality and improved hemodynamic status. Another recent data comparing chimney with basilica showed that chimney stenting was associated with a higher risk of complications. And for an optimal valve-in-valve TAVI, operators should be familiar to the technique of basilica and valve fracture as well, I think. Thank you for your attention.
Thank you for excellent lecture. Okay, let's move to the next topic. The art of sapien in Evolut, maybe about the TAVI in TAVI field by Andrei Pop. He's a system head of Sessions, Illinois Stroke Heart Program, and the medical director of Cardiac Cath Lab, Alexian Brothers Medical Center, right?
Yes.
Okay, could you start?
Thank you so much.
Yeah.
Great honor to be here. Thank you again for giving me the opportunity. So you all know about the characteristics of the Evolut frame. It's self-expandable, it's nitinol. The waist is obviously smaller than the base, which comes to be important when you talk about TAVI in TAVI. We know about the Sapien frame. It is stainless steel, cobalt, chromium, very, very hard material. The important things. The risk plane is the level where if you pin up the leaflets, you have risk of occluding the coronaries. The best way to define that is the top of the second diamond, the bottom of the second diamond from the top, or the sixth node from the bottom, and I'll show you that in the next slide. You create a neoskirt, and this has been very well described in papers mainly from the Vancouver group. And in most cases, due to the high frame of the Evolut, the coronaries are going to end up being below the risk plane. In rare cases, especially where the valve was accidentally implanted too low, you end up with the coronaries being above the risk plane. This is how you define the level of risk, bottom of the second diamond from the top or sixth node from the bottom. The neoskirt height is a function of how high you implant your Sapien valve. If you implant your Sapien valve lower, the neoskirt will be lower, but you end up with leaflet overhang. If you implant the valve higher, the neoskirt is higher, but you don't have leaflet overhang. This is a seminal paper, again, from the team in Vancouver with Dr. Akodad and Janar. They do a tremendous amount of good work in this area. This is what leaflet overhang is. Basically, if you implant the sapien valve lower, you end up having leaflet that sticks above, and it can actually work and serve as a second valve in line with the first valve. Short term, it doesn't seem to make a big difference. Long term, it's unclear what the implications are. It may have implications in terms of valve durability, thrombosis, other problems. So this is comparing two papers from the same group in Vancouver, showing you what the outer diameter on measurement is of an evolute valve in which you put a sapien valve in. And what's interesting is if you're comparing the two papers from the same group, you can see that when they measure the outer diameter of the sapien valve, that diameter is actually larger than what they're getting for the evolute valve. And that's important because that's telling you that basically the frame of the evolute constricts a little bit the sapien valve and doesn't allow it to open fully. This is for the 26 valve. You can see that the maximum diameter that they measured was 25.6, but the sapien should have an outer diameter of 27 millimeters. So this is something that's important and translates to every size, 29.7 versus 27.4. So that can be important, but can also be exploited. 34. Anyway, if you put the sapien lower in the evolute frame, you end up with less extrinsic compression of the valve by the evolute, which may make it more difficult to anchor. That is generally not a problem because the evolute frame is extrinsically compressed and you can leverage that. You increase the leaflet overhang, but you decrease the risk of sinosequestration, at least acutely. The problem with having underexpanded sapien, or for that matter evolute valves, is this thing called pinwheeling, which basically means that the leaflet is not straight. When you have pinwheeling, short term, your gradients may be affected. The problem is really long term. There's a suspicion that it decreases the durability of the valve and increases the risk of halt. So, a few practical points. Before doing a sapien in evolute, I always want to see the initial CT and the follow-up CT. It really helps to see what the valve looked like before they put the first valve in. You have to measure at every level the diameter of the evolute, because if the evolute is really constrained, you can use an undersized sapien valve and anchor in the evolute frame or in the leaflets. And you have to remember that the evolute leaflets start slightly above the skirt, so that has implications in terms of anchoring. In terms of coronary protection, previous speaker beautifully displayed how this should be done properly. I'm not going to belabor the point. Basically, we generally try to enter through the northernmost cell that allows us to engage the coronary, and the technique displayed in the last case was absolutely perfect. This is what we want to end up with. We flare the stent and we get it as open as possible. The problem with snorkeling is that once you snorkel, it's very difficult to come back and do another TAVR valve in there if it fails. And that's why I think Basilica and Shortcut and other such technologies have a major role to play in the future. So a couple of case examples. This is a 69-year-old man with cirrhosis, bicuspid aortic valve. We had treated him with 29 millimeter evolute 5.5 years prior. He was very sick at the time. The surgeons refused to operate, so we put an evolute in him. And as you can see, we actually imaged him right after implant. And you can see asymmetric deployment of the evolute, which is not surprising because he had a nasty bicuspid valve. You can see that there's still a lot of calcium in there. So we just moved the calcium out of the way, but that will be important when we're considering how to treat him. We protected him as you would expect, because the calcium was very close to the coronary, and we actually don't have the beautiful software that was shown in the prior case. And we ballooned to see what happens when we inject. And actually, it didn't look too bad. We ballooned with a 26 millimeter balloon. We weren't so impressed, but we wanted to protect anyway. We then landed the valve, the sapien valve, right underneath the snorkel. This is a technique that I really like, because that way you don't have problems interfering with a stent. We deployed it right where it needed to be deployed, and it looks okay. The calcium is in the vicinity, but it's not causing coronary obstruction. This was a case where I actually ignored the recommendations of Melissa Fusari, who told me to put a 23 valve in there, and I put a 26 valve. And next time I will not ignore her recommendations, because if you're looking at this frame, first of all, you see there's space between the two frames, and that's probably because of the calcified leaflets of the Evolute, which you can't get rid of the calcium. That has to go somewhere. And then the second thing that you can appreciate is if you're looking at the angle of the frame of the Edwards, it's not open fully. The angle is supposed to be 120 degrees, and that angle is not 120 degrees. So we came back, we did CT, and basically on the CT, you can see that the valve is open to 22 millimeters, and it's a 26 millimeter valve. So I should have listened to Melissa, and I should have put a 23 millimeter valve in there. But also this shows you the opportunity, right? In this situation, you could have gotten away with a 23 millimeter valve and you would have had a beautiful result. So lesson learned, you don't need to oversize inside the Evolute. You can go very close to the diameter of the valve that's in there, and you can leverage the fact that the Evolute frame is smaller to anchor in there. So this is another case where we had actually an 87-year-old who had had a perimount valve, then had an Evolute done in another center, and then had multiple admissions with heart failure and had wide open AI with an aortic valve leaflet prolapse. We went in, we measured everything, and we determined that the average diameter was about 26 millimeters. You can see the coronary heights. Let's see if this plays. I don't think this plays, but basically we deployed the valve underneath the snorkels like we always do, and we thought we were quite happy and we had a great result. You can see on this picture that this valve is much better expanded. So this made me a lot happier. The angle is about 113 degrees, so a lot closer to 120 degrees. And then one thing that we always do before we actually get rid of the stent in the coronary, so we take the stent out if the pressure is okay, but then we do an IVUS. And what this shows you is that you actually have a leaflet that's pinned by the wire that goes in the coronary. So what that tells me is that once I take the wire out, I don't know what's going to happen to that leaflet. That leaflet may occlude or may be okay. So we didn't want to take any chances, and this is still frames showing the same thing, and we just stented the left main, and I think we had a beautiful result. Interesting thing, at 3 months follow-up, so his mean gradient was 17. His mean gradient 3 years after the Evolute was 31, and his mean gradient 3 years after Perimount was 16. So we got pretty much to the same gradient. And that shows you that if you put a balloon expandable valve slightly supraannular, you can get very good gradients. This demonstrates what I talked about before. You always have to take into account the fact that the thickness of the leaflet has to be taken into account. This is in valves that are brand new. You can imagine in a heavily calcified valve how that space increases. And what that means is that if you put a 23 millimeter valve in a heavily calcified Evolute, the outer diameter of the Evolute, if the 23 millimeter valve is fully expanded, is not going to be 23. It's probably going to be 24 or 25. Also, the bigger the valve that you put in there, the more constrained it's going to get. So all this has to be taken into account when you're putting the valve in. The other thing that I'm going to mention in passing, if you have situations where the risk of coronary occlusion is really high, and if you have a surgeon who is actually willing to operate, this is a very elegant technique where the surgeons do a mini sternotomy. They make an incision in the aorta, they go in, they cut the leaflets of the evolute valve, they align the commissures of the sapien valve, and then they deploy the sapien valve under direct visualization. This is a very elegant technique for patients who are surgical candidates and want to avoid a major surgery. So in conclusion, the strategy depends on the pathology being treated. You can use a low sapien implant if you want to avoid coronary obstruction, if you want to seal a perivalvular leak. If you can use a high sapien implant when you want to anchor in the evolute frame, and the strategy has to depend on the anatomy and the failure mechanism. And then you have to balance the risk of sinus sequestration either acutely or later with the leaflet overhang risk and delayed sinus thrombosis. So I'll take questions at the end. Thank you.
Thank you, nice lecture. I introduce the next speaker. So Wei Shen In. He is the vice superintendent of the Chenshin General Hospital and the professor of the medicine at the National Yangmin Chiao Tong University, Taipei, Taiwan. He is also the past president of the Taiwan Society of the Cardiovascular Interventions. And today's topic is the art of evolute in sapien. Please, nice lecture.
Please show my video. Yeah. Please play the video. Yeah, thank you. As we know, the annual volume of TAVR has increased each year, and in 2019, TAVR volume exceeded all forms of SAVR, coincided with the US FDA approval of TAVR for low-risk patients. Among the patients younger than 65, recent US data showing that by 2021, the odds of a patient under 65 would receive TAVR versus SAVR were about 50-50. In this regard, TAVR has consistently shown better results than surgery, and the focus is shifting more towards valve performance, such as hemodynamics. Data from surgical AVR demonstrated that patients with moderate or severe PPM had increased risk of readmission for heart failure and reduced surgery. Survival are significantly worse for any degree of PPM. The use of a small prosthesis were independent predictor of 10-year mortality. Actually, higher residual gradient affect late mortality in both TAVR and SAVR. Severe PPM was associated with increased mortality and heart failure readmission at 1 year after TAVR. TAVR has consistently shown better results than surgery in forward flow hemodynamics. Although the differences in mean gradient after the procedure was slightly over 3 millimeter mercury, there was a fourfold difference in number of subjects with a mean gradient over 20 millimeter mercury in surgery compared with TAVR, and a threefold increase in the occurrence of a small area in surgery patients compared with TAVR patients. That is, a small differences in mean gradients appear to translate to a large difference in index of bioprosthetic valve stenosis. Through 5 years, significantly lower rate of bioprosthetic valve dysfunction with COVA or elevated R TAVR versus SAVR were demonstrated. Therefore, as we move the indication of TAVR to more active, younger, and lower risk patients, we should not tolerate PPM because it may compromise long-term survival. From the hemodynamic study, the gradient is proportionate to the area available for flow, which is related to the square of the EOA radius. Below 2 centimeter square, the area available for flow rapidly diminishes. Hence, we need to achieve an EOA of approximately 2 centimeters square before we can substantially raise aortic flow without a large increase in transvalvular gradient. In the TVT registry, in 62,000 patients that include patients treated with both SAPIEN and Evolute valves, severe and moderate PPM were present in 12% and 25% of patients respectively. The use of smaller prosthesis of less than 23 millimeter and the valve-in-valve TAVR procedure were important predictors of severe PPM. That is, in patients with a small annuli and the TAVR in SAVR procedure have elevated gradients versus patients undergoing TAVR in native valves. And there is a trend toward showing that elevated gradient have been associated with increased late mortality with a p-value of 0.09. Actually, among various available TAVR devices, the largest EOA have been achieved with supraannular self-expanding valves, approximate or exceed 2.0 centimeters square. Both the balloon expandable and the self-expanding valve that are approved in the US have been shown to be effective treatment options. With, however, balloon expandable valve demonstrate equivalent to the hemodynamics performance to the surgical valve, but self-expanding valve demonstrating superiority in terms of EOA compared to the surgical valve. In a recently published long-term follow-up data comparing intra versus supra-annular valves in mortality and the hemodynamic performance, intra-annular valve showing that higher transaortic gradient and the accumulated incidence of hemodynamic valve degeneration and the bioprosthetic valve failure predominant occurring in the smallest valve size 20 to 23 millimeter intraannular valve, even though the overall survival was comparable. In summary, for a substantial number of patients with a small aortic anatomy at high risk of PPM after TAVR, self-expanding supraannular valve demonstrated superior hemodynamics. In study in REDO TAVR registry, actually TAVR in TAVR shows similar outcome versus TAVR in SAVR. But specifically, TAVR in TAVR had a higher instance of a mild aortic regurgitation, but lower frequency of residual high valve gradient compared with TAVR in SAVR. What have we learned from TAVR in SAVR is that with the surgical valve in the native aortic annuli, there is a lack of space in the aortic root for the TAVR valve, which makes achieving optimal hemodynamic performance challenging. How to modify this? We can choose an we can choose a supraannular valve. We can put the valve higher, and we can use a bioprosthetic valve fracture. Small label size of the surgical valve is associated with inferior result after valve-in-valve procedure. In the adult sapien group, there was a negative trend between the bioprosthetic size and the high post-procedure gradient rates. That is, we should avoid balloon expandable valve in small surgical valves. Furthermore, implantation depth matters. In those patients, even with the self-expanding valve, if you put the valve too low, the under-expansion effect will be demonstrated because of the annula will constrain the opening of the valve. The higher position may allow for greater valve expansion, which is especially necessary in small bioprostheses. The restrictive effect of the surgical valve ring is increasingly modified by a technique that is known as bioprosthetic valve fracture. This method utilizes the inflation of a high-pressure balloon inside the surgical valve either before or immediately after the VIV procedure. As shown in this particular case, we use an Atlas balloon to predilate the 21 millimeter Edward SAV valve, and with a true ID of 19.5 millimeter, and then we can implant a 23 millimeter Evolute R inside. There has been no residual gradient after VIV TAVR. In the near future, we will see an increase in reduced TAVR procedure. While doing a TAVR procedure, we should consider the current risk, the commission alignment, leaflet overhang or deflection, and under or overexpansion of the second valve. Furthermore, we should consider the hemodynamic performance of this combination of TAVR in TAVR procedure. For instance, although the current risk is lower in TAVR with the use of short frame balloon expandable valve, and the risk is extremely high for the use of TAVR in TAVR with 2 layers of self-expanding long frame devices. Even though the use of balloon expandable valve in the balloon expandable valve for TAVR in TAVR is the current risk is lower. However, hemodynamics may be an issue. In this report, a patient with a balloon expandable valve in balloon expandable valve had a high post-procedure gradient and require surgical valve replacement about 1 year after the redo TAVR. As to the redo TAVR with BEV in SEV, although hemodynamic function was acceptable, but leaflet overhang and the higher current risk were noted. The good and bad of various combinations are shown here. The current risk level are high in SAVR in SAVR. Extremely high current risk and the questionable residual gradient are seen in this combination. For BEV in BEV, although less limited the current reaxis, but higher residual gradient can be expected. In BEV in SEV combination, lower residual gradient can be expected, but the current risk is elevated. The best combination might be SEV in BEV because this allows less limited coronary access and lower residual gradient. That is the fluoroscopy of a patient with SV in BEV. So valve choice today is also a valve choice for tomorrow. In conclusion, hemodynamics are increasingly important for both SAVR and TAVR. An important objective for the operator is to ensure optimal hemodynamics that will enable the best possible clinical outcome for patients with valvular heart disease. As we move to more active, younger patients, an EOA of at least 2 centimeters squared is a worthy goal. The lesson learned from the valve-in-valve for small surgical valves while enable optimal hemodynamics could be translated to those with failed transcatheter balloon expandable valve and the small native aortic valve. Available data support the use of TAVR over SAVR and favor the use of self-expanding valve over with supraannular leaflets to achieve optimal hemodynamics, especially in small annuli. I thank you for your attention.
Thank you, Vice Rector. I introduce the last speaker. This is Won-Keun Kim from the Karen Hope Clinic, GmbH, Germany. Today's topic is acute level 2, patient selection, tips and tricks, and the troubleshooting. Please, the last lecture. Speakerphone is off.
We cannot hear your voice.
Your speaker is
Dr. Kim?
okay.
Okay. Can you hear me?
I,
Can you hear me now?
okay.
And do you see my screen?
We cannot see your slide.
Okay, then I'll just start beginning. Apologize. Okay, now you should be able to see my slides.
Okay, I see your slides.
Okay, yeah, thank you. Thank you very much for the kind introduction, Professor Kim. Good to see you. I have heard very good, excellent talks so far. It was a pleasure listening to them. And I note it's a lifelong learning. My topic is a little bit off the road, but I hope you will enjoy it. I would like to introduce you the ECRED Neo 2, which is new in the market in Korea. And yeah, we focus on patient selection, some tips and trips, and probably less of troubleshooting. Here are my disclosures. You know, there are different generations. We first started with the ECRED transapical system back in 2012, which is not available anymore. Then in 2014, we received CE mark for the ECRED Neo. And a few years ago, the ECRED Neo 2 came into the market with only slight modifications. You see the increased skirt to treat PVL and radio PEC marker. Everything else is basically the same. There are new developments upcoming. Here's a short video showing the implantation steps for those that are less familiar. You can see that the upper crown is open during step 1 and then followed by opening up the stabilization arches in step 1. Then you verify the procedure. and can open the lower crown for full deployment. And usually this can be done on beating heart. I prefer to use fast pacing, sometimes rapid pacing, I'll explain later on. And I would like to start with patient selection. And I think it's important in general if we look for the best choice for each patient to look at different criteria. Of course, there are anatomical limitations. There are some valves that cannot be used in all patients only due to anatomical limitations, for instance, annulus size, etc. I think the highest priority always should be to achieve a good immediate procedural outcome. That includes safe implantation, safe deployment. We should go out of the procedure with no more than mild PVL. We try to achieve good gradients. We have talked a lot about it, and we should choose the valve with lowest coronary obstruction risk. And I think if you have two similar valves with expected similar outcomes in terms of good procedure, then you can start to think about future aspects, lifetime management, future coronary access, tough and tough durability, explantation, etc. So I think you can have a good future coronary access, but if you are not able to achieve immediate good outcome, then it's quite useless. And for the Accurate Neo, because it's new, I think it should be important to look at the strengths, but also at the limitations. I've highlighted some of the strengths. I've made experience in the past, but also limitations. And we know that the main limitation is next to the valve size availability. We can only implant up to 27 millimeters. Higher valve sizes are underway. But I think the greatest limitation is that in cases with very severe aortic valve calcification, and especially with eccentric calcification, there is some there's a downside to use the Accurate Neo due to incomplete expansion and higher risk of PVL. I think this is the greatest limitation that we should take into account. Of course, with the skirt of the Neo 2, the rate of PVL has massively dropped, but still I still see in very eccentrically calcified anatomies, there's still a higher risk of PVL. Let's start with some strengths. We all know that in horizontal aortas, it's difficult to implant with long stent frame valves. This is no problem for the Accurate Neo due to its self-alignment and the stabilization arches. This has also been shown in a large registry showing higher device success compared to the Evolut system. And also due to the very flexible system, you will never see any problems in crossing the arch. You will never have to use a snare in order to cross the aortic valve. And this is due to the very flexible system. We talked about gradients, which is also important for long-term outcomes. And we know that due to the supraannular design, the risk of prosthesis mismatch is lower, especially in smaller annuli, as shown in this comparative case example. We have a very low risk of coronary obstruction. I've shown you the rates of coronary obstruction of different registries. And this is also our institutional experience, which is quite low. And I think the main reason is that we try to select the best valve, and we have a relatively high proportion of accurate. And this may be a reason. Here's a case example with a very low-lying left coronary artery, and showing this comparison of what happens with the leaflet. When you look at the sapien, then you can see what happens with the leaflet and calcification, which is pressed just in front of the coronary ostium, whereas with the accurate, the upper crown is keeping away calcification from the coronary osteum. This is a quite atypical implantation. Also, we know that permanent pacemaker rates are relatively low. As you can see here, there are different numbers shown here. I think you should all be familiar with those. Of course, permanent pacemaker is a multifactorial aspect. And when I was in Korea, I was surprised to hear about relatively low pacemaker rates because the threshold probably is much higher to implant a pacemaker than in other countries. The accurate, nevertheless, has relatively low pacemaker rates, probably currently lowest pacemaker rates of its class. And I think one reason is the specific distribution of the radial force, which is relatively high here, where we aim to implant the valve, and the inflow part here, which is in the LVOT, has a relatively low radial force. So for the accurate valve with a nominal positioning, we will have good outcomes. There's no need for intentionally high positioning. We only need to avoid deep positioning. I'll talk about positioning a little bit later. TAVI explantation will be also important subject. There are different registry data out there, a little bit difficult to interpret. This is my personal perspective of TAVI explantation. I think it really depends also on the design of the valve and several other criteria. Valve in valve, this has been talked about extensively here. There are different options also for the accurate. And I think it's important to note that for the accurate, there is a VTA of 2 millimeter by default, as you can see here, because usually between the stent post and the leaflets and the upper crown, there's a space of 2 millimeters. So probably there is a relatively low risk of coronary obstruction when you insert a second valve. And we have seen this in numerous valve-in-valve implantations that we did as bailout for malpositioned or leaking prosthesis without doing commercial alignment or basilica. And actually, we've never seen coronary obstruction because of this specific design. Also, here's an example of what is possible in terms of valve-in-valve. Here's a implantation that we did actually as an emergent case with chimney stenting, so there was no time for to consider basilica. And you can see we implanted the chimney stent just right here, and we were able to re-enter the stent with the wire after the wire had been retrieved. You can see the result here. And we were able to really re-access this chimney stent. So maybe just a little bit different approach of a chimney stent and might change the view on it. So I would like to show you some slides on how to best position. And the marker band that came up with the Neo2 is a blessing and a curse, the same, because I think it really helps for the initial positioning, but it is important for you to not rely exclusively on the marker band alone. And I will show you why. You should always look at the relation between the upper crown and the calcified leaflets. This is the basic thing. And here in this example, I think you're way up too high and need to adjust the position. So I have shown some scenarios. If you have a so-called concurrent aortic root, then if the marker band is here just in the line, annular plane, then you will have acceptable position of the upper crown in relation to the leaflets. And even if the positioning marker is a little bit higher, just on top, of the annular plane, then you will see that there's a good relation of the upper crown with the calcified leaflets. However, this is obviously too low, both with the marker band and with the upper crown. And here you can see that we are obviously too high, both with the marker band and the upper crown. However, if you have a relatively large aortic root, then you can see that relying on the marker band alone may be misleading. And here, in this scenario here, in the concurrent aortic root, this may be okay, but you can see that you may end up too low with the upper crown and have a higher risk of embolization into the left ventricle. So I think this is really dependent on the individual anatomy. Please look at both the positioning marker and the upper crown. Here's a very nice example, as you can see. And if you look at the positioning marker, we are way too high, but you can appreciate that the upper crown is already lying on the calcification. There is no way to go deeper with the valve. And you can see it's here. If you would only look at the marker band, then you would say it's way too high, but you can see there's no other option. And in such cases, if we are not sure about or not happy with the positioning, then we are very generous to employ either fast or even rapid pacing, because this improves the stability massively. If you have, you need some forward push or forward pressure, and here you can see what could happen if you don't have sufficient forward pressure. And this is very difficult to measure, actually. And here on the left-hand side, you see appropriate push. You can see that the delivery system is in the outer curvature, and the stent holder moves to the LV after deployment. On the right-hand side, you see what happens if you push too much. This is a very hard push. And actually, this is also very difficult, but it's possible. And my personal opinion is, if you get too high, then you should really initially start to adjust the position. Don't wait until step 1 is complete. I think it's important to have immediate adjustment. You see this upward movement during step 1 quite frequently. And here's also a very nice example that we had recently. During step 1, we are still fine with the position. And you will note that during opening of the upper crown, the valve is moving higher and has ended up very high. This is too high. And what we did, over around 1 or 2 minutes, we slowly built up push, and were able to correct the position into an acceptable pre-deployment position and achieve a good outcome. So it's really important to take time. The push needs some time to translate into the position, especially if you have a lot of tortuosity or calcification. Finally, I would like to show you some new data that we did here, comparison of 3-CUS versus CUS overlap view. For the accurate neo, it's important, there is no big difference. You can use both views if you are familiar with the different views. The technique might be a little bit different, but this is because the accurate has a predetermined positioning, which is completely different than other self-expanding or even balloon expandable devices. This is very fresh and is just submitted data, which maybe shows for the first time the hemodynamic and functional impact of commercial alignment. This is data from 3 centers, RIX, Lucerne, and our center, and we show that there is some effect on hemodynamics and more aortic regurgitation if you have commercial misalignment. Finally, this is also submitted data comparing accurate versus Evolute, which is probably the workhorse in most centers for valve and valve TAVI. We did propensity matching, showed there's no difference in most outcome parameters. A little bit better in terms of pacemaker. So if you use accurate valve and valve, there's literally no risk of pacemaker implantation. I would like to summarize. I think it is in our responsibility to have a optimized selection for the patient. And regarding the accurate, I recommend to use mildly to moderately calcified aortic valve. You can implant the accurate also in severely calcified valves if the distribution of the valve is symmetric and if there's no eccentric calcification. There's probably the lowest risk of coronary obstruction and relatively easy coronary access. I've shown you that there's a low risk of conduction disturbances due to the distribution of the specific radial force without the need to implant too high. And I think I would like to highlight that, of course, high positioning is good in terms of pacemaker rate and hemodynamics, but you may have to pay a price in terms of coronary access, future TAF in TAF, and this has to be weighed, I think. Commercial alignment is easy, and I think the accurate could be considered as component in lifetime management. For positioning, please use both the marker band and the upper crown. Immediate adjustment in case of upper movement, and there's the need for sufficient appropriate forward pressure and in uncertain situations, considering fast or rapid pacing. Thank you very much for your attention.
Thank you, Dr. Kim. We listened to 5 beautiful lectures, and this is open to live discussion. We have 6 panels: 국형돈, 신상훈, and 승재호, 유재석, 리상록, 정우백. Please feel free to raise questions or comment. I'd like to ask Dr. De Beer. So, can you compare the success rate of Basilica in surgical failed valve versus native bicuspid valve, or the TAVI valve? Is the same success rate?
So we do not have a great comparison. It's only my gut feeling that I will describe. Obviously, it's a bit different. The challenge with native valves is the fact that they are always heavily calcified, almost always. These are AS patients, right? In failed bioprosthetic valves, these are sometimes very gentle leaflets. Sometimes they failed from aortic regurgitation, not because of stenosis. So it's easier sometimes to traverse failed bioprosthetic valves in general when you sit correctly behind the leaflet. However, when you have native tissue and not a bioprosthetic valve, there is not a lot of material in the aortic root that you need not to be entangled with. So this is the benefit of doing a TAVI in native valves. So there are no surgical valve posts. There is no ring that you need to avoid and not to go behind it. In general, it depends what anatomy you have when you compare these two, bioprosthetic valves and native tissue. For aortic root tricuspidization, for bicuspids not at risk for coronary obstruction, we do not have enough data to suggest whether the procedures are different than native cases coming for prevention of coronary obstruction. But the cases that performed to date in my practice were quite good.
Thank you. So in terms of shortcut device, so I showed the very good flashing system in approaching device to the leaflets, but many TAVI patient has very tortuous aorta. So I suspect in some patient the flashing system cannot work. What do you think about that?
The first patient that came for a shortcut procedure was a patient with extremely tortuous aorta with a post-bental kink in the narrowing in the ascending aorta, that I actually thought that basilica would be very complex and challenging. And that was the first in human case of a shortcut device. Until now, we did not fail with shortcut positioning, also in complex anatomies. It could be, and there are more than 50 cases to date. It could be that eventually we'll have very challenging anatomies. So surprisingly, I can say that the device works also in complex anatomies.
I have one question to Won-Gun Kim. We are discussing about the valve in valve, and we also discussed the sapien in evolute in sapien. But about after listening your lecture, it looks like the accurate neo 2 is best for the valve in valve system. How do you think about the outcome of the valve in valve about the accurate neo 2?
Yeah, there was not much time to go deeper into the data, but I think at least it's of course not a randomized comparison, but I think it's a relatively large number, and we show that it's feasible, first of all, and that you can achieve at least similar outcomes. In some aspects, I think there might be advantages using the accurate. We know that the evolute, we have to acknowledge that it's best in class for hemodynamics, but even the accurate neo seems to be similar for valve and valve. And I think there's a big advantage of the accurate neo in terms of coronary re-access. And we know that for coronary access, the evolute is worst in class, and the accurate is of course not as easy as the sapien, but I think much easier, especially if you have commissural alignment, than the supraannular valve. And just last week, I've treated one patient with degenerated accurate in bioprosthetic valve, and this patient had AR, and I was able to insert a second valve, a sapien. So without having any concern of coronary obstruction or coronary access. So I think this is a combination that you might take into consideration in your armamentarium.
I'd like to ask Andre Pap. So after listening to your lecture, I think of super overhanging is very frequent in sapien in evolute. So in cases anticipating overhanging, the considering it's better to consider evolute in evolute, or any advantage of sapien in evolute in cases anticipating overhanging?
Well, I think the reason that, I mean, ideally we would never have overhang. Ideally we would implant the sapien high enough that you pin up the leaflets and the coronaries are okay. But the reason that we do the overhang, we allow overhang, is to avoid coronary obstruction. So it's not something that we voluntarily do. It's something that we're kind of forced to do. And I think that it's something that always makes me nervous, because we have no data on the long-term effects of leaflet overhang, whether it's associated with a risk of sinus thrombosis, where it's associated with reduced durability. It's going to take years for us to get that information. I think also that you have to take into account, when you're thinking about leaflet overhang, how the valve failed. If the valve failed by aortic stenosis and it's heavily calcified, then most likely the leaflets are going to be rigid, and you're going to be able to push them away, and they're not going to have as much of an impact on the new valve. If the leaflets are soft and it's mainly failure by aortic insufficiency, then I think leaflet overhang is more problematic, and you have to think about the long-term implications.
Thank you. Any more questions?
So I have one question for Dr. Yin. So you have nicely demonstrated that these younger patients will be benefit from the larger effective orifice area. So this patient will be suitable with the supraannular designed valve. But ironically, the valve-in-valve procedure, you demonstrated that the self-expandable valve in balloon expandable valve will be the best strategy. So this ironic situation, so what would you choose to the first valve in younger patients in these scenarios?
Well, it depends on the root anatomy. If the anatomy is big enough, I think no matter which one would be better, would be okay. I mean, if it's a small annulus, I think supraannular valve will be a better option. And if the coronary is an issue, I would take balloon expandable as the first valve. That's my usual practice.
Okay, thank
Actually,
you.
in patient already have a sapien. Many physicians or many doctors put a second valve involved as using another sapien. I want to show that there may be problematic regarding the hemodynamics in the long run.
Yeah, we listened to 5 excellent lectures and there was a lively discussion, and it's time to close the session. Thank you for all the speakers, and especially Dr. In, Dr. Dibio, Dr. Kim. Yeah, it's night. I think it's just afternoon, but I think you are in the midnight. So thank you for your contribution to this symposium. So we'll see all of you next time. So thank you.